What did you guys notice from the reading? Anything?
There was a trend.
There was a trend. What was the trend? Yeah, they liked fluoride a lot, huh? So then some of the things that we've been talking about, they hardly mentioned at all. Do you have an idea why that was? Because they're sponsored by Colgate. So what kind of studies did they use? So what was the answer to number one? Yeah. So if you remember back to the article I had you read from Mrs. Hurlbutt, we don't always have all the randomized controlled trials that we would like. So some of these recommendations are kind of on the stuff that has the most research, maybe not on the stuff that's the most efficient. All right, number 2. How do you know when a carious lesion is arrested?
The hardness of the tooth surface
right.
on probing.
Hardness of the tooth. That's an easy one. So nobody said anything about having 6 questions instead of 5? So I did that because I was afraid this was a little harder, and I didn't want, if you missed one, I didn't want it to count for so much. So it's still 10 points, just they're not each one worth as much. All right, number 3 is a little harder.
What's it?
Okay, by popular demand.
Advanced cavitated lesions on coronal
So
surfaces.
this is what they've recommended. It would probably work on permanent teeth, root surfaces as well. But this is the one that has the most research with it. Okay. Again, there's a trim here.
5% and they have varnished 2 times.
Okay. And so number 5. No, I think we're at C.
Yay. More high quality.
So even they recognized that they didn't have as much research or evidence as they would like. So we got off of the A's and the B's here. Okay, then question number 6.
True false?
C, there you go. So when you're reading these articles, what I want you guys to get used to doing is I want you to think about it. Don't always just go with what they said, but I want you to think about what you're reading as well. All right. Let's see if we can last part. How was you guys' weekend?
No, I think this is the last week.
Oh yeah?
Yeah.
The whole class?
Yeah.
Very nice.
That's what they were saying earlier.
Mine seemed a little bit short. I don't know what you guys think. It just seems a little
Yeah, we're short. Rocky.
But then I've been short my whole life. So. Okay, so today we're going to talk a little bit more. It's kind of a continuation of last week's lecture, but this has a little bit more to do with not so much with prevention, but more of treating carious lesions. So one of the things I would like you to remember is that so my dental students have an issue with this. And sometimes they think that if they don't have a drill in their hand, then they're not treating the lesion. But just because you're not cutting on the tooth doesn't mean you're not treating the lesion. So we're going to talk about a lot of treatments today that don't involve cutting away the tooth, because you can never put it back. I mean, we can play it putting it back with amalgams or composites or porcelain or gold, but it's never the same as the tooth that was originally there to begin with. Okay, so here's your little cheat guide for today. These are the things I want you to know. So you're going to need to know what minimally invasive dentistry is, and you want to know what different alternative treatments for minimally invasive dentistry are, and when and how to use them. We're going to go over the ICDOS and the ADA caries classification system a little more in depth than we did when we first introduced it at the beginning of the quarter. So you'll want to know how those work. And then we're going to go over silver diamine fluoride a little bit more. So you want to know what it is, when you need to use it, or more specifically when you shouldn't use it, and how does it work. Okay, so minimally invasive dentistry, there's actually a journal of minimally invasive dentistry. So they came up with a definition back in 2009, and it's just an evidence-based discipline that deals with the oral hard tissues and soft tissues, and primarily it focuses on saving these tissues rather than taking them away, because the optimal health for the tooth is but preserving as much of it as we can. As hard as we try and as good as we're getting at replacing missing tooth structure, nothing that we do is as good as what you're born with. Okay. So really, minimally invasive dentistry is all about doing, maybe not doing less, but cutting less. So this is definitely a less is more sort of a thing. We're going to focus on prevention, focus on conserving healthy tooth structure. Definitely we don't want to remove more tooth structure than is absolutely necessary. And if possible, we want to heal the tooth structure that's there already. So we have a bunch of different treatment options. We're going to go over these today a little bit. We went over some of them last week, but we're going to go into a little more detail today. There's fluoride. Fluoride is, it's been around for a while, but it's been around for a reason. It's because it works. So we'll talk about fluoride. We'll talk about the ACP, CPP, the MI paste. We'll talk about some nanohydroxyapatite. We'll touch on the biomimetic blasts and the self-assembling peptides. Go over resin infiltration a little bit, bleaching, microabrasion, sealants, the conservative adhesive resin restorations. Some people call them a preventative resin restoration. They're basically just an overgrown sealant. So they're just kind of like a sealant where you just prep the grooves a little bit. The atraumatic restorative technique, we'll talk about that. And then we'll talk on just a little bit on some of the things that need some more research as well. So you can kind of divide these treatment options up into a couple of categories. You can divide them in a couple of different ways. But one way to look at them would be some of these are more preventative and some of them are more therapeutic. So some of the ones that are a little more preventative would be like the fluoride and the sealants, the essential oils and the laser and the ozone. We don't have as much good information on those at this point, but they tend to be a little more preventative as well. On the other side, you have some of the therapeutic interventions, like the resin infiltration or icon therapy, the microabrasion, the conservative adhesive resin restorations, or PRRs, whatever you prefer calling them. the GI restorations, the MI paste and this nanohydroxyapatite, the silver diamine fluoride, the atraumatic restorative technique. These all tend to be more therapeutic. They tend to treat existing lesions already. But before you can decide, how you're going to treat them, you have to be able to identify these lesions. So it falls back on diagnosis a little bit. So the problem with the visual method of diagnosis is it's really good at identifying large lesions, but not as good at identifying the smaller lesions. So the IC-DOS and the ADA caries classification system, they give us a rubric to use the visual caries identification, just help it be a little bit more objective, a little bit more precise. And then the radiographs definitely help with seeing where your eyes don't go. Okay. So the International Caries Detection and Assessment System is a 2-digit code that is applied to every tooth. So the first digit is does the tooth have a filling, or is the tooth a virgin tooth? So if there's no restoration or no sealant in the tooth, then it gets a code of 0. And then depending on whether or not they have a sealant or a tooth-colored restoration or an amalgam restoration or some sort of other indirect restoration, you get the appropriate code. The second digit describes the carious lesion. So if there's no carious lesion at all, you get a 0, and then as the carious lesion gets larger, you get a progressively larger number. Okay, so the initial, so they've broken these carious lesions down into 6 categories. So that's and it's a little bit tough distinguishing between initial caries and the first distinct visual changes in enamel. They're kind of hard to see clinically. As you get farther down, it gets a little bit easier to distinguish between these. But up until this point, so codes 0 through 3, it's just the carious lesion is just in the enamel, and it's not until number 4 that you start getting a cavitated lesion. So for all of these codes below number 4, you can remineralize these lesions. So these are all reversible lesions from 1 through 3. 0, there's no lesion at all. So but once you get into 4, then you get your first dentin involvement. And definitely once you get into the 5 or 6, where you have the distinct cavity, those ones it's irreversible. Those ones are going to need some sort of surgical intervention. Notice the difference between 5 and 6. 5 has a cavitated lesion, but it's less than half the surface of the tooth. 6 is a really big cavitated lesion. It covers more than half the surface of the tooth.
What slide number are you on?
We don't have that one.
We have a different one.
Well,
We have this
nuts.
one.
We also don't have like the learning objective slide.
Well,
We're missing a couple.
you will get those soon. As soon as I finish the lecture, I thought I'd give you this updated one, but maybe not. So this is, I added this one just to, because I didn't think you had enough information. I talked about it on the last time I did this lecture, but I thought that having it written down might help more. But I'll make sure and change that file for you. Thought I had changed it already, but I guess not. So because here's another new slide for you. Because the differences between codes 1 and 2 and 3 and 4 were kind of minimal and hard to visualize. The ICDOS made a clinical set of codes, and they call them their merged codes. And so these ones are sound tooth structure. So instead of a numerical value, they gave them a descriptive value. So you have sound, initial, moderate, and extensive. So your extensive caries are the ones with the obvious cavitated lesions. The moderate, they grouped 3 and 4 together. So these would be your initial cavitated lesions, the small cavitated lesions. And then the initial caries is where it's just limited. And the reason they did this, so they have an e-learning. I thought I included that file in your module also, but they have an e-learning module on their website, and they have a little quiz that after you've gone through their little e-learning course, you can take the quiz and see well you do. I've yet to pass the quiz because I can't tell the difference between a 1 and a 2, and I keep getting them mixed up. It's just that those codes are so close together. So clinically, they recognized that this was a problem, and they made these merged ICDOS codes. So this is the International Caries Classification and Management System website, and they have the e-learning module on that website where you can get even more information on these codes. The important part to remember is at what point are you going to try to remineralize these lesions, and when are you going to have to treat them surgically? So maybe number 4 you can treat by remineralizing them, but definitely after 5 and 6 you're going to have to treat these surgically. Okay. So they have a little decision tree to help as you go through to decide what is the diagnosis for this tooth. And I'm not so worried about you guys knowing this decision tree. Just know that after code 3, then your chances of treating the tooth with remineralization are starting to diminish. So code number 4, maybe you can remineralize the tooth, but definitely codes 5 and 6, you're going to need to be treated surgically. One of the reasons that ICDOS changed their clinical diagnosis was probably due in part to the ADA caries classification system. So this came out around, when did this come out? About 2007, I believe. And the major improvement on this over the ICDOS system was that it was a lot easier to make the diagnosis between the categories. And they added in this radiographic part as well. So their classification system is just these 4 descriptive categories. So you have sound tooth, so this would be your healthy tooth, initial lesions, moderate lesions, and advanced lesions. And so you can see here the description of each one. The major difference between this and the merged IC-DOS codes is that they've added in the radiographs as well. So a sound lesion is going to have a radiographic code of E0, so no lesion in the enamel. Your initial lesions will be your E1, E2, and D1 lesions. So your E1 lesions are going about halfway through the enamel. Your E2 lesions are going up to the dentinal enamel junction, and your D1 lesions are just within the outer third of the dentin. And then your moderate lesions are going to you're going to have visible signs of enamel breakdown, so it's going to be a cavitated lesion. And there's some dentin involved as well. Okay. And on these ones, your radiographic code, you're going to have dentin within the outer 2/3 of the, or you're going to have decay in the outer 2/3 of the dentin. And then with your advanced lesions, these are the large lesions. Enamel's fully cavitated and dentin is exposed. And radiographically, the decay goes into the inner 1/3 of the dentin. So this curious classification system merges the visual and the radiographic diagnosis together. So if you have a D3 lesion, you have an advanced lesion. You can't have an initial D3 lesion. They don't match. Okay. Does that make sense? Okay. So here I wrote it down for you so it's a little bit easier. You don't have to remember what I droned on about. But the E0, no radiolucency. E1, outer half of the enamel. E2, up to the DJ. D1, outer third of the dentin. D2, outer 2/3 of the dentin. And the D3 is in that inner third of the dentin up to the pulp. Okay. So research has shown that if you have a non-cavitated D2 lesion, you can remineralize up to a D2 lesion. There's not too many lesions out there that extend into the inner 2/3 of the dentin that aren't cavitated, but when you can find one, you can remineralize up to that D2 depth. Okay? But most typically, you're going to have more success remineralizing up to this D1 level here. Okay? So before the D1 lesion, so if you go back here, up to your initial lesions here, these ones you can remineralize. These ones over here, you're going to have to treat surgically. Okay? So that will be an important thing for you all to remember. All right, so how are we treating these? I've been telling you, you have to treat it surgically, you have to treat it by remineralizing it. So what are the treatment options? So for your IC-DOS codes of 0 or your ADA carries classification codes of 0, we probably don't, these are your sound teeth, these are your healthy teeth. So we probably don't, there's nothing really to treat, but we definitely need to focus on the preventative therapies like fluoride and good oral hygiene, good dietary habits, all of those sorts of things. Once you get into your IC-DOS codes of 1 through 3, or your ADA carries classification codes, the initial lesions, then you have to have some sort of intervention. And these ones you can treat with remineralization. So whether you're remineralizing it with fluoride or nanohydroxyapatite or the ACP, CPP. These are the ones that you're going to need to remineralize. You can use resin infiltration on these lesions as well. The resin infiltration lesions treatments are going to work best on the smooth surface lesions. The conservative adhesive resin restorations, or the PRRs, these are going to be more in the pits and fissures of the tooth. Okay. And the microabrasion kind of goes along with the PRRs, and it's just a little sandblaster that you use to clean out the loose bits of tooth from the pits and fissures. Okay. So these ones, this is kind of the line between remineralization and invasive therapy. Once you get into the ICDOS codes of 4 and above, or the ADA codes of let's say moderate lesions, then you're looking at more invasive therapies. So these are your cavity, your lesions that are already cavitated. Okay, so you can use the. You're going to have to do some sort of filling, but the GI restorations are good. In one of the advantages of the GI restorations is that they act as a fluoride reservoir, and so they can help to prevent further decay just by releasing fluoride over time. Once you get into the ICDOS codes of 6, or the advanced ADA caries classifications lesions, then you're worried about pulpal involvement. How close are you to the pulp of the tooth? So these ones, you can use the atraumatic restorative technique. Sometimes you'll use that you'll use all of these 3 together. The atraumatic restorative technique is where you just scoop out most of the decay. You leave a little bit of decay in the deeper portions. You put a provisional restoration in on there. Let the body make some secondary dentin underneath it, and then you go back in and finish the treatment at a later time. These are done mostly for pediatric patients where behavior management is a little more of an issue. You don't have time to go in there and clean out all of the decay. So it's just a method of buying you a little bit of time with these younger patients. We used it mostly before the silver diamine fluoride was available. Now with the advent of the silver diamine fluoride, the ADA or the FDA approval of the silver diamine fluoride with these younger patients, we can just paint those cavitated lesions and buy some time that way. It's probably a little bit more effective as well. The indirect pulp cap is for really deep cavitated lesions, and it's just where you put a little bit of glass ionomer or some calcium hydroxide or maybe some MTA over the part of the lesion that's just right next to the pulp horn, and then you put a filling on top of that. You got a question?
Apply silver diamine fluoride to mask the lesion and put restrictions over that.
So the question was, is if the lesion is deep enough, can you put the silver diamine fluoride, can you treat it with the silver diamine fluoride and then put a restoration over the top of it? And yes, the silver diamine fluoride is kind of an interim step, and at some point you're going to have to replace the missing tooth structure from that cavitated lesion. So the research has shown that you can bond to the stained, remineralized silver diamine treated tooth surface, and you get the same sorts of bond strengths as you would with a normal tooth surface. It's just that if you use a pretty translucent composite directly on top of that black tooth, it's going to shine through. So you're going to have to use some sort of opaque layer first, and then put the composite on top of that. So usually you put a little bit of glass ionomer over the top of it because it's much more opaque and it tends to hide that black stained tooth surface there. So these ones, if you're treating these very deep lesions, we're assuming that the nerve is still healthy. So as long as the nerve is healthy, then you can treat these. If the nerve is inflamed, then it goes over to the endodontist, and they got to do a root canal, and all bets are off. So these are only for healthy teeth. Okay. All right. So let's talk a little bit more about the silver diamine fluoride. It's a relatively new caries management product. We just got FDA approval back in 2014, so it's been a few years now. There's a bunch of different ways to spell it out. If you're a computer or a chemistry nerd, you can do it this way. If you're going to write it all the way out, this is how you spell silver diamine fluoride. Lots of times people will just abbreviate it SDF. There's a bunch of articles in the literature where they spell it this way, and this is actually if you spell it this way, this amine group is actually NH2 instead of NH3. So if you're a nerd, you don't do it that way. You do it with two M's, but it probably doesn't make a lot of difference because in the literature you can find it either way. Okay. So I said it's new, but there's really not that much new out there. They've been using this in some form or another back to the early 1900s. They had a house solution that they painted on the teeth, and they used this up into the 1950s. And there's a bunch of clinical studies done on silver fluoride, and silver fluoride combined with SN10 fluoride. There was a bunch of studies done in Australia and even in Japan back in the 70s and 90s. And so there's a lot more research out there on the silver diamine fluoride than you would first think when you realize that it was just got an FDA approval back in 2014. But they have randomized controlled trials done on SDF, and so we have some good evidence that it works. And finally, it only took 100 and some years for us to get FDA approval for it in the United States. So there's hope we can get some new stuff in here. But it works in three different ways. So it inhibits the demineralization of the dentin. It inhibits destruction of the collagen matrix, and it also has a bactericidal effect where it inhibits the carcinogenic bacteria as well. So it works in three different ways. With the inhibition of the demineralization, you get an increased surface hardness of the dentin. So once you've treated the tooth with the silver diamine fluoride, that remineralized lesion is actually harder than the healthy tooth surface around it. So there's an increased mineral content of calcium and phosphate in that remineralized surface. And part of the reason is because the little enamel crystals in there are the silver diamine fluoride tends to make them better organized, so it aligns them closer together, so there's less of the collagen spaces in between it. And this makes it harder and more resistant to demineralization. I think I mentioned last week the zombie effect. You get little particles of silver diamine fluoride incorporated into the tooth. And if you demineralize that tooth again, so if you put acid on the tooth again, it releases those silver diamine particles, and it just starts the antimicrobial cycle all over again. So it kind of has a built-in safety mechanism as well. The silver has been known to be antibacterial for a long time. But the silver will destroy the cell wall structures. It denatures the enzymes within the cell. It messes up the DNA replication, and it also interferes with the attachment of the bacteria to the tooth itself. So it attacks the bacteria on a number of different fronts. The way that you use it is you paint it on the tooth every 6 months, and once you've done that, you can put a control restoration over the top of the lesion. If it's in a aesthetic area, or if that cavitated lesion is in an area that collects plaque, you can put a control restoration over the top of it. But if it's not in a high area of plaque retention, or if it's not in an aesthetic area, or if you have a little squirming 2-year-old that you just can't get to hold still long enough to place a restoration, you can just leave the treated lesion just as it is. Okay. So they've tried using the potassium iodide on top of the silver diamine fluoride to decrease the black staining, and it works a little bit. Instead of being a really black stain, it's only a slightly black stain. So, and the potassium iodide comes along with so many different side effects, as far as lots of people have severe allergies with the potassium iodide, that the effectiveness of it just didn't outbalance the potential for complications. So now people don't use the potassium iodine so much. They tend to just mask it over with a control restoration. The procedure for using the silver diamine fluoride is a little bit complicated. There's like 12 steps in here. Most of it is keeping silver diamine fluoride from staining the patient, the operatory, the operator. Most of these things tend to deal with just keeping the silver diamine fluoride on the carious lesion. So you gotta cover everything. You have to have PPEs for everybody. You have to use a saliva ejector, and you have to use petroleum jelly, so Vaseline, to keep the silver diamine fluoride isolated to just the tooth. You had a question? So the control restoration can be anything, but the glass ionomer tends to hide the staining more. But you can put amalgam or crowns or whatever over the top of it. So once you have the tooth isolated and everything else isolated, you dry the tooth surface, and then you just use one little drop of the silver diamine fluoride on the lesion. So you just have a little micro brush, dip it in there, and place it on the tooth, and that's it as far as the treatment goes. Once you've put that drop on there, you leave it for a minute, remove the excess with a gauze or a cotton roll, and that's it. You rinse the tooth and you're done. So most of the work here is just with the isolation. And once you're done, you have to be careful. So when you're collecting everything, if there's a little bit of the silver diamine on the cotton rolls that you pick up, if you get that on your gown or on your scrubs, it'll stain those again. So you have to be careful when you're cleaning up to keep it all together and don't let it drip on anybody, because it stains everything. If you get it on mucosa, you get it on skin, the staining is temporary, kind of like a henna tattoo. Once your skin grows new skin or your mucosa grows new mucosa, it'll go away, but it's going to be a couple of weeks. So if you put a big spot right here on your patient, they probably won't be terribly pleased with you. Okay, so definitely some disadvantages, because it definitely makes a big black stain where the caries was. There are some people who are allergic to silver, so you definitely don't want to use it with those patients. You're using fluoride, and fluoride can be toxic in high doses. But again, you're only using one drop per lesion, so unless the patient drinks the bottle, you're probably not going to get a fluoride toxicity. There have been some cases where the gums they've reported some inflammation of the soft tissues where the silver diamine got on there. And then the staining issues, because it'll stain tissues and soft tissues, and it'll stain clothes and dental chairs and whatever it gets on. Okay. So because of these disadvantages, you're going to want to choose your cases carefully. So you use this on cavitated lesions, if you remember from your article, and usually in people where the caries is out of control. So you have rapidly progressing caries. So this would be your kids with the bottle caries or early childhood caries, whatever you want to call it. It'd be with your older adults when the root caries is just out of control. It can be used also for people, so your methamphetamine addicts who are not using meth any longer, but you got to get the caries under control. You can use it for them as well, or any time where you have xerostomia. So cancer patients, anytime that you have xerostomia-induced caries, where the caries is just progressing really rapidly, this will work really well. But you just have to explain to your patient, or to the patient's mom or dad, this is an interim step. Once we get the caries under control, then we can address the unsightly black stains. Usually for these people, they're pretty desperate, and so they're okay with that interim step. They're tired of going to the dentist every 6 months and having a half a dozen new caries being diagnosed on top of fillings that they just had placed 6 months ago. So these patients they're ready to do just about anything, especially if you tell them, once we get it under control, then we can make the teeth pretty again. You guys have already seen patients, you've probably seen extensive caries and how unsightly that is and how it affects the patient's behavior. Lots of times they won't take their hand away from their mouth, they're embarrassed. So you're not really making them any less sightly. You're not making those lesions more ugly because they're already ugly. You're just stopping them. And if you tell them, that's a little harsh, I know. If you tell them, we got to stop it first, and then we can address it, and we can make it pretty after we get the disease under control. Then they're usually on board with that. So it comes in this little bottle. It's not very big. The little bottle costs like $125. But again, you got to remember you're only using like 1 drop per carious lesion. So maybe 1 or 2 drops per quadrant. And when you figure out into the equation how much you're using, it's actually more cost effective than traditional fluoride treatments like varnishes or foams or gels, because you have to use a lot more of those a lot more often than you do the silver diamond fluoride. So yeah, when you shell out $100 and some for a little bottle, it kind of hurts a lot, but it only it lasts a long time because you're only using a little bit at a time. You definitely don't want your assistant to leave that uncapped and let it evaporate, because those are just dollars evaporating into the air. So you definitely have to let them know that it's just like silver. And so it costs money. And then you get reimbursed for this as well. There's an ADA code that allows you to charge the patient's insurance, so you get reimbursed for this as well. Patients don't have to pay out of pocket for it. All right, so a few different references, and that was it. That was just the kind of the tail end of last week's lecture, because last week's lecture was a little bit long. Okay. So any questions regarding the lecture today? Yes.
So, the silver diving bars and
So for your lesion that's treated with the silver diamond fluoride, you treat the lesion with the silver diamond in first, stains it black, you try to mask it out with some glass ionomer, and then over the top of the glass ionomer you can place a composite or a ceramic restoration or anything. But you need something opaque like glass ionomer to hide that stain. Alright, so for next week, I hate to disappoint you all, but I won't be making you a quiz for next week. I'm hoping you guys get over it. Yeah, life's tough.
Always a but.
Oh, yes, everybody, there's always a but. So I will be giving you an assignment next week. So, but I'm going to go over next week's lecture is just some cases. So we're going to go over some cases in class, and I'm going to give you guys some cases, and your assignment will be to go over those cases like I did with the ones in class. So you just follow the leader, do it like I did, and you should be doing just fine. Okay. I will get this last updated lecture posted for you. I apologize, I thought I hadn't done it already. But you guys have those lecture objectives for each lecture, so that should work for your study guide. Any questions, email me, track me down on the clinic, whatever you got to do. typically my office hours are Friday morning. It seems that they've kind of settled down into the Friday morning area. But if you have questions, definitely come talk to me before the final as opposed to after the final, because it's a lot easier for me to make changes before.
Is the final cumulative or just?
So the final will be cumulative in the sense that a lot of what we've gone over since the midterm kind of builds on what we learned before the midterm. But I won't be asking too many questions like on straight up facts, like what is critical pH, or well, I might ask about fluorosis because some of you guys got confused on fluorosis, so I might ask that one again. But most of it is going to be critical thinking. So you're going to have to put together everything that you learned in the first part, and then you're going to have to apply it to the questions. So about a third to a half of the questions are going to be case-based questions. So very similar to what we're going to do next week in class. There'll be 3 or 4 little case vignettes that you will read, and then I'll ask a number of questions from each case vignette. So you're going to have to pull all the material together. For example, the case may say that the resting pH for the patient is like 6.6. So that's not too far off of normal, except then you're going to have to remember that the critical pH of cementum, so exposed root surfaces, is around 6.5. So even though it's not too far off from normal, you're going to have to realize that this patient's at risk for root caries, and so you're going to have to kind of put the information together like that. So it's still going to be multiple choice, but you're going to have to do a little bit of critical thinking. You're going to have to pull information in, answer the questions that way. So kind of easier, kind of harder, different. Usually the results on the midterm are similar to the results on the final. So prepare, because it'll challenge you a little bit. Yes.
So as far as my study path that I did for the midterm, I didn't do good on the midterms. I took all the objectives and just wrote out the answers to them. And I think because it was so much information, I didn't know what to focus it on. And then you're saying there's certain things that you want us to take out. Is there a study guide so that we're able to pull those things out, or do we need to study everything?
Yeah, pretty much. I'm going to try to I'm going to try to pull about the same number of questions from each lecture. So and I'm going to try to cover each of the lectures since the midterm fairly evenly. So pretty much, yeah, know the lectures that we've gone over. The readings, those kind of things are going to be supplemental to the lectures. I'm not going to take any questions from the readings, but you're going to find information in those readings that are helpful. So if you're having troubles with a certain concept, then maybe go back to the readings on those, or come talk to me. Good? Guys get an extra 55 minutes today.
All right. Adios.
I don't know if I have my name.
Is your name Keith?
This question.
Oh, sorry. I almost hit you.
I saw